So now we move to another hope from the robotic surgery, the Professor Rick Satava. Please.
Thank you very much. I yield. Nat, you've got it. All right. I'm Robot's Hope. And it really is hope, but why is this called Robot Hope and Robot Hype? Why isn't it Robot Hope and Laparoscopic Hope? Is there no hope for laparoscopy anymore? What is laparoscopy? I think laparoscopy is the end of the industrial age and robots are the beginning of the information age. So I have to confess that I am prejudiced. And if I can get going here. There are my disclosures, and as you can tell, I'm on a grant from Intuitive Surgical, but it's to develop a simulator and curriculum that is becoming standardized for robotic surgery. So with that preliminary, and I didn't know that Mark was going to mention about the automobile of the future, which DARPA has indicated that without question, we now have cars that are capable of driving themselves safer than when humans do. But let's take an analogy once again to transportation, is what you'll see here. Transportation at the turn of the century, when industrial age was coming to the forefront, the standard transportation was what? Horse and buggy. Only $59. And the cars were $850, the very first one. A decade or more later, what did we have? Well, we had only $61 for my horse and buggy, but we were at $240 for our car. These were the value propositions at that point in time, and the transportation using my horse and buggy clearly had the advantage. It was way too expensive for me to buy an automobile. So that's where we are today. Remember, of course, that laparoscopic surgery began in its clinical ascendancy in approximately 1990. And robotic surgery really didn't get started until about 2005 with commercialization. The studies that my colleague has been able to show you are comparing 7 years experience with 20+ years experience in laparoscopy. If you all recall the enormous debate between open surgery and laparoscopy, at the beginning, we almost didn't have laparoscopy because it was too expensive. Why would you want to buy a $30,000 laparoscopy system when your scissors only cost $100 or $150? Why would you want to go ahead and introduce laparoscopy with a complication rate that is 2 to 3 times what open surgery would be? Because that's what we had, the crisis and common duct injuries with laparoscopy. Fortunately, we don't have that with robotic surgery comparing to laparoscopy. Complication rates are relatively the same. So, and maybe even better. So the next question would be, where are we going to go with this, and where are we now? Well, if we use the same standards before and don't change what we have now, a century later, if you will, between the standard in transportation then and the standard now, I think the value equation unequivocally is in favor of the automobile instead of the horse and buggy. So those of you who have a buggy whip, you probably don't need to pull it out now and go back to that. We have made the transition, and we are in the information age, so why are we using industrial age technologies when we're living in the information age? So what is a robot anyhow? It is not a laparoscope, and it's not a machine. It's an information system. And as I've told many before, it has the capabilities. Just like a CT scanner is not a machine, it's an information system with eyes. And it now integrates fully into the new level of technology, which is the information age, not with the old technology that was from the industrial age. These are the things you can do with robotic surgery. You can't do open surgery with a laparoscope, but you certainly could do it if you would choose to with the robotics. This is an unfulfilled opportunity that we have yet to plumb. We can do, as I mentioned, remote telesurgery, and there's some issues with that as well. And because the Da Vinci system was not designed to do remote surgery, we've not taken advantage of that. There are new SI would give us that capability if we choose to go that way. It's almost impossible to image-guided surgery with laparoscopy. It's a native talent that is part of the robotic surgery system. If we wanted to, and we don't, but if we wanted to, like Jacques Marisco does, we could import patient-specific data and in essence give ourselves X-ray vision. And once again, with image-guided surgery, and we can also do simulation and training all on the robot, the same instrument that we're going to be doing the surgical procedure on. But here's the important thing. We are not sharing the data. A robot is an enterprise investment. It's made by the hospital. But as surgeons, we are not sharing that information. We should be sharing it throughout the hospital because as an information system, it knows everything that's happening, either by analysis of the video images that's coming to my eyes or analysis of the electronic signals, the information I'm sending to the hands. It knows whether or not I'm making a mistake. It knows whether or not I've done a number of procedures. Why do I have to, at the end of every operation, dictate it? A robotic system has the capability, although we've not plumbed into it, to actually automatically do the dictation for you. It knows what you've done. It's seen your hand motions. It's been watching the procedure. It can do that. What about credentialing privileges? At the end of the year, I have to fill out a piece of paper documenting all of the operations I did. The robot knows all the operations I've done. Why do I have to spend all that time? Why are we not sharing that on the enterprise? Every time a tool is changed and gets discarded, why don't we send that information down to inventory control so they can order it automatically, rather than taking a half an hour or more of my nurse's time filling out paperwork and ordering new things? These are the capabilities that are inherent in the system that they were initially designed to do that we're not taking advantage of. There are a lot of other potential ones that are under research or have not been taken the opportunity. Virtual mentor. It can watch the way you've done this procedure or the way a master has, and while you're operating in real time, can alert you to when you may or may not be making an error. Why don't we do warm-up and rehearsal on that, on the same one that you're going to be doing your procedure with? It can detect errors very simply. And what about no-fly zones? Aircraft have no-fly zones on them. There are certain areas that are so dangerous that the aircraft alerts you that you should not be there. This is a capability that we can import into our robotic systems. We can begin automating portions of this procedure, for example, automatic anastomoses, not too much different from, for example, staplers that are, in essence, an automatic anastomosis. Next generation image guided, being able to integrate energy systems within the actual robotic system so they can control them, controlled at the speed that a robot works. A human works in milliseconds. If you're lucky, you're able to react to something in 100 or 200 milliseconds. Robotic systems work at microseconds. 1,000 times faster they can detect and react than the human body is. And as Mark had mentioned before, this is a tool to enhance our capabilities, not to replace us. And the newer systems that are coming out are going to be self-assessing and self-adjusting. So as things change, they're automatically, in real time, able to adjust the directions that they're going. So that's the directions that we're going. And this is the fundamental change. You can stay in the industrial age and use mechanical instruments, or you can move into the information age and use, for example, information and energy to control your surgery. Here's a new intelligent instrument that it's coming. It's got LEDs in there for detecting blood flow, just like your pulse oximeter. It has shear, pressure, and other strain gauges to tell the amount of pressure, and it can display that information back to you. And this is the beginning of the direction that we're going for haptics. Energy systems, and I was just in the other one, such as HIFU, being able to do diagnosis and treatment simultaneously with the same instrument. And so you can have a diagnostic ultrasound looking for Doppler, and when you see the bleeding, press the button and automatically stop the bleeding without needing to do any cutting and tying and so forth. This was the example that I have shown in the past, that you're actually able to detect bleeding And if you use a concentric, high-intensity focused ultrasound around a standard diagnostic ultrasound, there's the Doppler of the internal iliac artery in a pig. We've just lacerated. This pig will die in 15 minutes, 100% mortality. However, because we had the HIFU, we pressed the button, and when we turn the Doppler back on, there's no more bleeding. So we have instantly been able to do what would normally take a much larger and longer procedure. These are the things that we can do today. This is the technology that's available, and the question is, should we or should we not implement them? But, you know, what are the future things, similar to what Mark had mentioned, that we would be able to do? What is radically new that maybe or maybe not come to fruition? And for those of you who've heard my lecture before, I apologize, but these are the capabilities. As a prelude, this is a cockroach. I hate this cockroach, God. But anyhow, this is a cockroach, and it's got probes in its brain. And at UC Berkeley, they would run this on a treadmill to understand why it is the most efficient motion machine on this planet. After 4.5 billion years of evolution, it better be efficient. And so one day, what happened was that the students went back to the lab at nighttime and disconnected the wire from their brain and connected it directly to a joystick and began driving that cockroach around the laboratory. $3.5 million of your tax money to drive this cockroach around. I was quite disappointed, and I'll show you in a moment why that's important. But just think, if we would have had these available with that tiny little camera that's in your cell phone, maybe 1,000 of them, at the World Trade Center, or at the tsunami, or during the earthquake, they can go places that humans or even dogs couldn't go, and we probably could have saved many, many lives. We are now miniaturizing robots. We're looking at the current version of the robot that's commercially available, but we're also looking at next generation. This given capsule is actually a robot that is the equivalent of an endoscope that you swallow and it passively records things. Next generation is going to see how can we navigate these and actually control them and do things rather than just seeing things. Femtosecond lasers. This is the next generation of energy. Most lasers are continuous, but if you pulse it, so each pulse is only 1 times 10 to the minus 15 seconds, a femtosecond, and you shine this on a cell, what you're able to do is make an incision without causing damage and reach inside that cell. Optical tweezers, nanotechnology, and you're actually able to manipulate the individual organs inside of the cell. Or, as they have done in Dundee, Scotland, be able to actually get inside of the nucleus, removing bad genes and replacing them with good genes. And where can you do this? You do it at a workstation. This is where the cell biologists now are doing genetic engineering directly by changing individual chromosomes like they are in Scotland. But we already have that capability. We just haven't implemented it. We don't even have to invent something new. It's there. We just have to use the capability that exists today. We're going to have to retrain ourselves because in the future, if we do cellular surgery, this is what it's going to look like. And in order to be able to determine whether or not you've been successful in your surgery, you're going to have to look and determine whether there's a color change, not a structural change, because these are individual molecules that you're going to be changing. The blue dots that you see here, this is from Dundee, Scotland, and the places where you see the bright spots are the places where they've actually removed bad genes and replaced them with good genes. Below it, the thing that looks like Mount Fuji actually is an ion channel. And this is where all of the action happens for cells. You get your proteins or your transcription factors or whatever, they go through the ion channels. And we are working now with atomic force microscopes to be able to get in and outside of those ion channels, giving them the type of factors that they need or closing it so they cannot escape. So there are a number of technologies that way beyond anything that we've ever done before. Where do these crazy ideas come from? Well, how about Robert Heinlein, 1955, science fiction. The trauma pod. This is the remote surgical robot that was actually supposed to, at that time, save the lives of soldiers on the battlefield. Well, we're halfway there now. We've got those robots, but it only took us 70 years to get there. Other ones have done that. The point being is that it's not only about what can I do today and what is the potential that's in the laboratory, but it reflects exactly what this entire title of this is. It's about hope. Is there no hope for laparoscopy? Is our only hope coming from robotic surgery? Are we stuck now in the 1990s and the 2000s? Or are we going to move forward and improve upon what we have at this period of time? So one of the final technologies, getting back to my cockroach with the probe in its brain, is that I can imagine doing things that I previously was not able to do. But even with some of our robots, my hand isn't good enough to control that. But what we see here is the group from Brown University that had multiple probes in an array. They put it into the brain of a monkey, and they would teach that monkey if it would move the red dot to touch the green dot, that a robot arm would come and feed them while they were recording the brain patterns. And then what they did is the same thing they did with the cockroach. They disconnected the wire, and they would take it and they would connect it directly to the robotic arm. Takes the monkeys about, it takes the monkeys to about 2 weeks to realize that they don't have to move their hands in order to feed themselves. So we've got 5 universities in the United States controlling robot arms with their thoughts. This was a little bit more successful than they expected, and so they began clinical trials with Jeffrey. Jeffrey's a quadriplegic, and after 3 months, they began the first experiment with him. How could he control things with his own thoughts? So the first thing they did is connected him up to a robot, up to a computer, and what you see now is Jeffrey trying to draw a circle simply by thinking. Not the perfect circle, but nevertheless, it's a circle. They've also been able to give him a program so that he can turn on and off a television with his thoughts. They weren't sure how much he could do, so they brought a prosthesis. This is unplanned. This is the first time a human has ever opened and closed a prosthetic arm just by thinking. Where we're going with the next generation of this, I'm not 100% sure. But I can imagine things on the nanoscale that my hands are not capable of manipulating. Perhaps in the future, you will be thinking your way through a surgical procedure. So these are the various hopes that we have. I prefer to look ahead rather than look behind. And I'm not denigrating the importance of our evidence-based medicine, but if we bank our entire future on retrospective or prospective studies without looking to what the potential is, we will be stuck here in the 21st century forever. Thank you.
Thank you very much, Professor Satava.